Now, one thing that I always tell the residents and the students that I work with is that this is not linear. So sometimes a resident will hear me talk about MI, and we do a large series, and they have a great session with a patient, and the person comes in pre-contemplative about their smoking or something like that, and at the end of the session they're ready to call the quit line and they're going to do something about it, and 2 weeks later, well, now they're questioning it, and the resident comes back and says, well, it's not working. And I always remind them, it's not a linear process. It's kind of like this. And hopefully, if we're trying to get here, we're going to go like this, and hopefully the overall trajectory is going in the right direction, but it's not likely to go like this. Okay? So stages of change. Okay? Now, one of the problems with this is that people are complex. And so you're going to very often be at a different stage for different problems. I don't know how many times I've seen in the substance abuse world, I got a guy who's, let's say, dealing with a very serious heroin addiction. And he's in an action phase, decides, I've got to do something about my heroin addiction. And he actually signs up, and he's ready to go to a detox and a 28-day substance abuse program. And he gets there, and there's a big sign on the door that says, no smoking. Well, he's pre-contemplative about his nicotine addiction, right? He's action about his heroin addiction. He's pre-contemplative about his nicotine addiction. Humans are complex. And if you buy this model, then you have to recognize that each behavioral problem, people are likely to be in different stages, and we got to do stage-wise assessment of each of those things. Okay? So how does this thing work? And this is theoretical, but there's basically two components: a relational component focusing on spirit, and a technical component focusing on actually language. Okay? So here's two fundamental ideas. And again, the physicist and the IT guy and the watcher, who is no longer watching. Okay. But anybody should be able to understand these two ideas, these fundamental ideas. Okay? And these, I think, really are absolutely critical to understanding what this thing is all about. So one is called the paradoxical effect of coercion. Okay? If a health professional takes up the good side of an ambivalent behavior, the patient is more likely to argue the other side. Okay? And this is, I mean, think about anything about which you might be ambivalent about. Let's just say that you get a great job offer. Job of your dreams, okay? But it means moving from your home to another place. And now you're talking about, is it really worth it? Should I take this job? Should I take my kids out of school? What about this and that? And you're discussing it with your spouse, okay? And for you got to make this decision over a period of a month or two. And some days you're feeling like this is the right thing to do, and other days you're feeling like, no, I shouldn't do this. You're ambivalent about it, okay? So if you come home from work and you say, you know, I don't know, I think it's really important to keep the kids in school, then what's your spouse likely to do? Or if your spouse says that, the idea is that if you take two humans and you have them in conversation about something about which one of them is ambivalent, if one of them takes up one side of the argument, you know, honey, I really think you should take this job. I think it'll be good. Then what's likely to happen? What's that? Yeah, it's like an invitation. It's like, okay, let's play. You're going to take up one side of the ambivalence? I'll take up the other side of the ambivalence. You want to take up one side? I'll take the other side. I don't care. There's two sides to this. That's what ambivalence is really about. And anybody engaging in a problematic behavior is experiencing, is going with one of those sides, but probably has the other side somewhere within them. So I can buy that in the model that we just talked about. But the confusing thing is, if you believe this, well, by virtue of me being the doc and wearing a white coat, I thought it was my job to always take up the good side. But if I'm always taking up the good side of the argument, you should stop smoking, you should eat less, you should take your meds, you shouldn't beat your kids, am I somehow inviting my clients or my patients to take up the bad side? I always knew that doing this, explaining, warning, scaring, I knew it didn't work. But it never before occurred to me that not only might it not work, it might be doing harm. And we sort of had to take this Hippocratic oath. Am I supposed to read that? I don't know. Does it say, like, stop talking? 10 minutes? Seriously? Wait, well, that's going to change things a lot. I thought we had like an hour. I thought we had like an hour. No? We don't? Okay, I don't know. I don't know. I don't know. Anyhow, let me... What? Maybe. Let me tell you the second key piece of this, okay, which is really important. So there's a huge mound. The psychologists in the room probably know this literature better than I do. But there's a huge amount of literature that suggests the truism of this statement. That the more we hear ourselves, we tend to believe and act on what we hear ourselves say more than what the other person says. So if we are putting voice to one side of the argument, if we are advocating for one side of the position of an ambivalent behavior, there is no question that we are more likely to act on that, okay? The more we hear ourselves defending the behavior, the more committed we are to sustaining the status quo. The more we hear ourselves talk positively about change, the more likely we are to change, okay? So basically the bottom line of MI is this little thing right here. It's arranging the conversation so that it is the client rather than the clinician who is putting voice to the argument for change. Now, it is not some form of trickery or reverse psychology. I am not suggesting that we say, I think you should smoke. I think that's a good idea. No, it's not about that. It's really about recognizing that someone who's engaging in a problematic behavior probably does see both sides of that behavior. And instead of getting on, if we envision it as a seesaw, instead of us always sitting on the side of the seesaw that is arguing for the good side, and therefore inviting the client to sit on the bad side, if we can somehow get ourselves in the middle, okay, and allow the client to explore both sides of the argument, and skillfully, by how we respond to their statements, and they're doing most of the talking in this technique, not us, by reinforcing, jumping on when they give voice to the positive, our goal is to make them talk about the positive aspects. And that's really where a lot of this is about. And in the simplest form, the implicit theory suggests that if you're going to do this thing, you're going to get clients to give voice to the change. And the more they give voice to the change, the more likely they are to change. And the more, the less they talk about all the reasons that they shouldn't be engaging in the behavior, the less they're likely to engage in that behavior. That's it in a nutshell. There's a lot. Now, again, it's not trickery. So there is a book. This is an actual book called Instant Influence. How to Get Anyone to Do Anything Fast. The only motivational approach scientifically proven to succeed in less than 7 minutes, okay? It has about 1,000 references in its bibliography. 999 of those are motivational interviewing, okay? Now that is antithetical to the spirit of this approach. So much so that when the people who really think about this had been the spirit. We'll talk about this. Collaboration, evocation, and acceptance. But in response to this concern, because a good car salesman knows all of this stuff. A good car salesman is not going to tell you, you should buy this car. He's going to come up to you and say, oh, you're looking at that car. You know your cars, don't you, sir? He's going to evoke from you what you're looking for in a car. He's going to make it a collaboration. He's going to, right? But what he's not doing is he doesn't care at all about compassion. Okay, so we've added compassion to this because we don't want the trickery business, right? It's a deliberate commitment to pursue the welfare and the best interests of the others, to prioritize the other's needs above our own. Okay? Without this, the manipulation of the other for self-interest remains possible, and we don't want that to be what this is about. So I have all kinds of interesting things to tell you about the origin, but we're not going to get there if we have to end in a few minutes. Yes?
After 10 minutes, the children will come in to sing, but they will be 10 minutes and then they leave.
Oh.
And you can continue.
Singing is good. All right, whenever the children want to sing, we should have the children sing. You tell me when the children sing. Okay. This is a fellow by the name of Bill Miller, still very active in the world, and he wrote the first paper on MI back in the early 80s. And the story of how he kind of stumbled onto this is interesting. He was a substance abuse researcher, and he was probably a little further than some of the PhD student. He was an early assistant professor doing his thing, substance abuse. And he was preparing for a clinical trial comparing two different therapies for problem drinking. And he was training some counselors in both methods. And then it was a research study, so there were some independent observers rating a variety of things about whether these people were adhering to the behavioral therapy, right? And one of the things they measured was the extent to which the counselors manifested empathic understanding during treatment. That was just one of the measurements. And what he found was that single measurement was more highly predictive of the outcomes than which arm of the trial the patients went into. So whether they got treatment A or treatment B mattered less than the degree to which the counselor demonstrated that they were hearing and understood where the patient was coming from. And that accounted for a ton of the variance in outcome, both short-term and long-term, okay? And there are lots of studies since then that have shown the same kind of thing. And that got him started. And then he did a great thing, which we don't do enough anymore in the States at least. He took a sabbatical. And he was on sabbatical, and he went to a place called Bergen in Norway, and he was doing training of psychology grad students or postdocs. And he said that they were different than American students in that they were much more rigorous. He would be, doing demonstrations of sessions with patients. And rather than them just shaking their head, they say, why did you say this at this time? What was the theoretical underpinning of this statement? Why did you choose to say this? And he says, well, it seemed like the right thing to say at the time, But they didn't like that, and they made him think about it. And he says that forced him to verbalize and actually really figure out why he made statements the way he made them. And he went on to write this theoretical paper about it, because what he realized was that this was a driving idea. This idea of having the client rather than the counselor verbalize the argument for change. And when he went back, and this is the early 80s. Now, I don't know how it was in Portugal or in Greece, but in the early 80s, the prevailing model of substance abuse treatment had almost nothing to do with anything that looked like this. In fact, what it looked like was this. It was, shut up and listen. Your best ideas got you here. Now sit down and I'll tell you what to do. Okay? That is a very different model than the MI model, which still has a clear leader and direction. We are not abandoning our role as advocating for the good, but we recognize that unless we're extraordinarily sensitive to our client's lead, it's not going to work. So this is a very different kind of idea. And when he went back and he looked, he found that a lot of what he was saying and thinking could be traced to lots of different people. And Carl Rogers, this is, for those of you shaking your head, this is highly Rogerian. But it's different because Rogers is really more of a client-centered, I'll follow you. Most docs are, just listen to what I say and everything will be fine. So a leading method, Rogers is a following method. This is somewhere in between. This is a guiding method. I know my way around here, but you need to tell me where you want to go, what kinds of things you want to achieve, and then the two of us will come together. So, but Rogers was a huge influence on him. Fessinger's cognitive dissonance theory was very big. Darrell Bem's reformulation of self-perception. He could trace the sort of theoretical underpinnings of a lot of what he would do therapeutically to lots of people, but he couldn't find previously stated in the literature this idea which he thought was fundamental and fundamentally different and important of specifically arranging the conversation so that it's the client rather than the clinician making the argument for change. And that really was a big, really got this thing rolling. So I'll just briefly go through this and maybe the children will sing afterward. But basically, they did a bunch of interesting things just to give you a little taste of this. Really interesting, I think. Here was a study that he did shortly after coming back from Bergen. And he piggybacked it on to existing funded research trials that were looking at 3 different types of treatment for substance abuse, 3 different programs. And all he did was, he said, before you get into one of those trials, let's take half of the people who are going into those trials and sit down with them for an hour and have an MI-style conversation with them about why they're doing this program. But use MI. And then the other half, we'll just let them go into the program, okay? And in all 3 trials, rates of abstinence at 3 and 6 months were double or more for the MI pre-treatment group. So having that conversation prior to the trial. So what does that tell us? One is that this is effective at small doses. And 2 is that it may not be the treatment, but it sure is a good adjunct to the treatment. So it's not like let's have an MI conversation and life gets better, but it's if we can use the treatments that we have available to us with an MI spirit, those treatments are going to be more effective. And I think the children are probably ready to sing, which is great. Every talk that I give from now on, I am going to have children come in and sing in the middle of. Okay. We're ready. Okay, you guys ready? They're ready. The question is, are you ready? And the other thing I will tell you is that I have not figured out a good way to incorporate the MI spirit into my pedagogical style. So from a teaching perspective, I'm doing exactly now what MI would tell me not to do. Right? I'm giving you all this, you just listen to me and everything's going to be fine. Okay? Opposite of the MI spirit. And there are certain people who have figured out a way to do that. I can do that in longer trainings, but in this, which is really an exposure, I just haven't figured out how to do it efficiently yet. I got a certain amount of information to convey, and I'm going to convey it. But I recognize that it's not in an MI style. Yes?
Do you work with graduate students?
I, as a psychiatrist, work primarily with medical students and with residents and with practicing psychiatrists.
So can you use the method with those?
Again, for me, it has more to do with when I do an exposure training, like a 1 hour, 1.5 hour. We have a 7-month, course, and I'm much more able to let them do the experiential work and kind of tell me, case-based, about frustrating cases they've had, things like that. Things differently. So you'll have to just forgive me for my MI non-adherent teaching methods. So, okay, so this is, I think, where we were. Basically, it's just by history, so this is early 80s. MI was kind of off and running, bunch of random controlled trials, mainly on substance abuse, generally positive. The first textbook came out on motivational interviewing in the early 90s. And importantly, for those of you who are interested in disseminating evidence-based practice, which is a tricky thing to do, and keep it fresh, I think they've done a good job in disseminating MI without making it sort of, here's what you have to do, and you have to do it exactly this way, and sort of dampening innovation. And one of the ways they did that was to create this network of trainers, and it basically started getting increasingly accepted within the substance abuse world, not only in the US, but in many places, Scandinavia, Australia, New Zealand, Asia. By the early part of the 2000s, there was a second edition of the main textbook, even broader approach acceptance in the substance abuse world, ongoing attention to dissemination and thinking about how to disseminate, more than 200 trials, many of which were randomized control trials, and importantly, and then just within the last couple of years, exponential growth in research. We're talking about a fairly substantial literature at this point, more process research. From my perspective, what's been most interesting is expansion of its applications with other modalities and systems, recent textbook. Okay, so we saw that in terms of the spirit, when we saw the cardiology simulation, what was clear there is that there was no collaboration, right? It was all one-sided, right? The cardiologist saying you got to lose your weight, you got to stop drinking, you got to stop smoking. He didn't seem to understand that the interview was occurring between two equal partners, both having knowledge that might be useful. And as a matter of fact, the name motivational interviewing in some ways doesn't do justice to some of these core principles, because when we think of interviewing, we think of, okay, I'm going to do the interview. I'm going to ask the questions and you're going to tell the answer, right? But the reason that they chose the term interviewing came from this idea of the view of one thing between two parties. So I have a certain area of expertise as the professional that I'm going to bring to the table, but you as the patient or client have a whole big set of areas of expertise, and that you understand yourself, your environment, what you're likely to do, and the two of us together viewing the problem can perhaps be more helpful. So that's the interview. It's an inherently collaborative versus authoritative approach. It's very much about me as the clinician not instilling within you, you should change because, but trying to evoke from you, why might you want to change? Right? And truly an understanding that motivation for change and the ability to move toward that really rests within the client. and the extent to which the clinician supports and actively fosters the perception of choice as opposed to trying to control the behavior choices. So, very much about, we want to make things right? We want people to do the right thing. And so the hardest thing in doing this is what we call the righting reflex, right? So you're making good progress on someone's desire or thinking about stopping smoking, and then they have a slip, and the first thing we want to do is say, oh, but you were doing so well, right? We want to make it right. If we really believe the paradoxical effect of coercion, then we've got to actively try to suppress that reflex to always take the good side, to make it right. We've got to resist the righting reflex, and it's hard. We want to help people. We have to find a different way to be helpful. We really want to understand a client's motivation, and the biggest complaint that I get from people all the time is, I don't have enough time to do this. I only have a 7-minute appointment. I only have a 15-minute appointment. If your time is limited and everybody's time is, I would argue that it's a hell of a lot better use of that time to truly understand what might be in it, why a person might want to change, than to waste the time, as we saw in that example, throwing all kinds of words at them. Okay? And if they can't come up with anything, then your job is to help evoke. And listen. Most of the time you spend in a visit, if you're a medical student, next time you're going on rounds and watching your supervisor, one quick way that you could do a fidelity measure to how much that person is in an MI spirit is simply try to track how much of the conversation is the clinician doing the talking, and how much of the conversation is the patient doing the talking. In an MI spirit, the patient would be talking the majority of the time. And what the clinician would be doing is one of the key skills, and we'll talk a little bit about it, but it's reflective listening, which is a real skill set that you can develop. And he would not be judging, criticizing, blaming, or imposing. Okay? And he would be empowering. Thinking aloud about the why and how of change is more likely to do something about it. And he'd be supporting self-efficacy. So let's take a look. Can we get back to the video for a second? Control room person? I wish I knew his name. With the phone, I'll call you. Okay. So let's take a look just at the same amount of time, about 5 minutes. And what would it look like with an MI Spirit? I'm going to have to get to it. So I'm going to have to get to the menu somehow. So I think it's here. Yeah. Okay, and I think it's, there we go, right here. So this setup is, let's picture a guy who just has had some sort of a pulmonary, like a bronchitis or something, and he's a big-time smoker, but he's otherwise healthy, and he's seeing his primary care doc or his pulmonologist or something like that.
Okay, well, if you get the prescription, take a few days off work now.
Okay.
And if that chest infection doesn't clear by this time next week, will you come back and see me?
Good. Okay.
Okay.
I'll do that.
Look, before you go, could I spend a couple of minutes chatting to you about your smoking? Because I know from the records that you're a smoker.
Sure, as long as you don't start to lecture me.
No, that's fine.
Because I get a lot of people nagging me about my smoking.
Sure.
You know, I know I should probably cut back, but you know, it's something I have a hard time with.
I promise I won't. And I don't see it as my job to harangue my patients.
Okay.
What I'd like to do is to try and understand exactly how you feel about it. Is that okay?
Sure.
I want to ask you 2 questions. Each one of them, you give me a number. Okay?
Okay.
The first one, how important is it for you right now to stop smoking? If 0 was not at all important and 10 was very important, what number would you give yourself?
Well, probably on a scale of 0 to 10, I would say about 6.
Right, right. And the second question, how confident are you that if you did stop today, that you'd succeed? If 0 was not at all confident and 10 was very confident, what number would you give yourself?
3.
Right, right. So you're not convinced you'd last?
That's something I would have a hard time giving up. I'd have a hard time giving up my smoking. Right now, I think.
And you gave yourself a score of 6 on importance.
Mm-hmm.
There's a part of you that thinks it's a good thing to do. Why did you give yourself a score of 6 and not 0?
Well, I definitely think, you know, smoking has some importance to your health. You know, we constantly hear that from ads on the TV and, you know, from people like yourself.
Well, for you personally?
Well, I don't think it's the most important thing for your health, but, you know, that's why I didn't give it a 10. But I think has some importance. But it's just something that right now I don't really feel confident that I could quit right now.
I was going to ask you that. You know, if what would have to happen for that importance score to go from 6 to say 9 before you decided, oh yeah, I really want to do this?
I think I'd have to be convinced that I would feel a lot better and that I'm going to be healthier, and I'd have to feel confident that, you know, that I could actually quit. You know, if I could actually make some progress, you know, that might help. But, you know, I need a bit more convincing because, you know, my grandfather's 92 and he smokes a pack of cigarettes every day, and, you know, he's 92 and he's been smoking for years. So I don't think it's the most important thing, but.
So it would take quite a lot for you before you really decided to give up?
You know, it would save me some money if I quit. That would be a good thing. But you know, it's just something I don't have. I just can't see me doing it.
It's something that you probably will do for the rest of your days.
Well, I know I'd like to quit in the future, but it's so hard. You know, everyone smokes. You know, and I've tried before, but you know, it's just something I have a difficult time with.
And how do you feel about my role in coming down to the doctor? And do you feel I've given you a lecture?
Not really a lecture. No, you haven't lectured me. I think, you know, made me think a little bit, I guess, but, you know.
The use of motivational interviewing in healthcare consultations. It's important when talking about strategies not to lose sight of the spirit of it.